Good morning, and welcome back to UCI Mind's monthly Facebook Live series, where live viewers have the opportunity to ask questions of our nation's leading experts in Alzheimer's disease and related dementia research. My name is Chelsea Cox, and I'm the Associate Director of Education for UCI Mind, which is one of 32 NIH-designated Alzheimer's disease research centers in the nation, and the only center right here in Orange County. Here in Orange County at UC Irvine, we're a collaboration of over 100 faculty, staff, and trainees who are at the forefront of solving Alzheimer's disease and related dementias. And in this series, we aim to bring our experts to you so that you can interact with with researchers and ask your questions. And today, I am so delighted to be joined by Dr. David Sultzer. Welcome, Dr. Sultzer.
Thank you.
Thanks for being on this episode today. Before we get started, I'd just like to briefly introduce Dr. Sultzer. He recently joined the faculty of UCI in 2019 after more than 20 years at UCLA and the West LA VA Hospital. He currently serves as professor of psychiatry and human behavior in the UCI School of Medicine, and he directs clinical research operations for UCI Mind. As a geriatric psychiatrist, Dr. Sultzer has dedicated his career to understanding the behavioral manifestations associated with Alzheimer's disease, and he is internationally recognized for his research accomplishments in this area. Dr. Sultzer received his medical degree from the University of North Carolina, and he completed a residency in psychiatry and a fellowship in neurobehavior from UCLA. Dr. Sultzer, again, thanks for joining me to talk about this very important and pretty common topic of behavioral symptoms in individuals with dementia that a lot of patients and families experience. I'm sure we'll get a lot of good questions today. And thank you very much to all of you who are attending and joining us live right now. We encourage you to participate in this open Q&A with Dr. Sultzer by typing your questions for him into the comments box. Please do remember, though, that whatever you post will be visible to others and linked to your name. So remember to post responsibly. And as you think of your questions, try to keep them, if possible, more general rather than personal. So we'll go ahead and get started, and I have a few questions to ask Dr. Sultzer while we wait for some of your questions. Dr. Sultzer, first, what exactly do we mean when we say behavioral symptoms, and what are some examples of these types of symptoms in people with dementia?
Yeah, it's a great question, Chelsea. It's a pleasure to be here today and have the opportunity to chat with folks online here too as well. Behavioral symptoms, we tend to think of illnesses like Alzheimer's disease and other cognitive disorders, dementias, as having two components of symptoms. We most often think of the cognitive symptoms, memory, perception, and problem solving, as being kind of the most important and the most obvious and define the illness. Another set of symptoms are those that are these behavioral or non-cognitive or neuropsychiatric symptoms, all similar terms for the same thing. So for example, cognition, memory, visuospatial skills, language function, behavioral, agitation, irritability, anxiety, mood symptoms. And when we think of the kinds of symptoms that are common in Alzheimer's disease in this non-cognitive or behavioral domain, anxiety, apathy, irritability, and mood symptoms are probably the most common.
Okay. And in a disease like Alzheimer's, at what stage and how often do people experience these types of behavioral symptoms?
Yeah, unfortunately, that across the span of illness in somebody who's got Alzheimer's disease over time, almost all will have some of these non-cognitive symptoms. They're essentially a fundamental expression of the illness itself. The brain manages information, things like memory and language in specific ways, but our behavior, our response to stress, our response to emotional issues is also directed by brain function, so that it's not surprising that nearly all will have some symptoms. It varies quite a bit across people and across different symptoms. Things like anxiety are fairly common, apathy are fairly common. Those like symptoms such as delusional thoughts or beliefs that someone is taking their things or hallucinations or agitated or aggressive behaviors tend to be less common, but affect about a third of people over their course of illness. Those latter symptoms tend to occur later in the course of illness, often in kind of the mid phase, when memory impairment is usually, unfortunately, substantial. And then many people in advanced dementia actually have fewer of some of these symptoms. So there's sort of this characteristic pattern over the course of illness.
Okay. Why do some people, maybe there's an answer to this question, maybe there isn't, but why do some people experience these symptoms and others don't? And does it have anything to do with a person's personality before they received the diagnosis or their life experiences, for instance?
Right. No, it's a great question, because obviously how we respond to things, how we feel, how we address stress is very personal and developed over our entire life experience, and older adults have a lot of life experience. So it's not surprising that people have different ways of approaching and experiencing things and responding to different things. But I think overall, you can think of kind of what's behind it as two categories. One is the biological features, and our group has been particularly interested in understanding that. Why do some people have some of these symptoms and why others don't? And is there something about how their brain is functioning or how the illness has affected certain parts of their brain that have an impact on the likelihood, at least, of these being expressed? So there's certainly some evidence there that illnesses, that symptoms like delusional thoughts are linked to changes in the brain in certain places, and that when people have those changes, they're more apt to have delusions, and if they don't, they're less apt. There's also the life experience or psychological or personal or cultural issues as well, that some people, for example, a colleague of mine did a study looking at for aggressive behaviors, which are fortunately not common in Alzheimer's disease, but do occur sometimes with verbal aggression in particular, that those with Alzheimer's disease, with aggressive symptoms, if you look over their lifespan, were more likely to be aggressive earlier on in their life. So I think it's not surprising on one hand, but also speaks to the importance of the individual and the personal aspects of these that are based on our life experience over many, many years.
Okay. And for those who do exhibit behavioral symptoms, what are there things that cause it? Are there certain triggers, I guess, that might cause a person to act out or experience?
Yeah, absolutely. The things we've talked about thus far are kind of underlying risks, if you will, biology, how the illness has affected the brain, personal experience. And then triggers are the things that happen in the hour beforehand or so, where that's something that's really important. But because when it comes to management, avoiding triggers is as important or more so than what do you do if there are behavioral symptoms. And some of the triggers are kind of included in two different categories. One is sort of the environment and the other is interpersonal. With the environment, it's really a theme here is stress. That people, if you can imagine not having an ability to fully understand exactly what's going on around you and interpreting, these are folks with moderate dementia, and that not being able to understand that can beget fear and stress. And so from the environmental point of view, we're looking, triggers include things like noisy overstimulation, if you will, large crowds. They're just less calming and more susceptible to people wanting to be aware, and a fear aspect can enter in. And when people with cognitive impairment are fearful, how they handle that may be less than ideal based on compared to how others might do that. So environmental stress is a key trigger. The interpersonal realm, it's really affect and interpersonal links. And for example, spouse carers, that someone with Alzheimer's disease, even with moderate memory impairment, can be exquisitely sensitive to whether their spouse carer is happy, sad, or upset. And that we've learned over time that when the carers are upset and concerned, which is often the case because some of the behaviors and symptoms are distressing, that can add to the distress experienced by the person with dementia. So that leads to kind of to avoid triggers and to try to manage the stress that carers experience. Not only is that good for them, but it's good for their relationship with the person with Alzheimer's disease and can reduce the likelihood of the person being more upset and fearful and concerned, because they may not be able to fully understand what's wrong, but they understand that something's wrong from someone that they care about. Yeah. And that care feeling is unaffected by the illness. So it's really, they're sensitive to, perhaps more sensitive than others might be.
Yeah, I think that really speaks to the importance of ensuring that there's, resources out there for caregivers to learn how to cope and work with their loved ones with dementia.
Absolutely.
And you also spoke to the experience of, environmental factors that might be triggers. And I think that we can kind of all put ourselves in those situations and understand when we're exposed to uncomfortable experiences that we feel a little bit uneasy.
Exactly.
Just as a person with dementia would.
Exactly.
Yeah.
And to extend that, I mean, it's common where people want to have their loved one, their elderly loved one, at the holidays go to the East Coast to visit family. And that's something that we all may do depending on where our families are located. We'd all acknowledge it's a little stressful sometimes because it's the holidays. Yeah. But when someone with Alzheimer's disease travels cross country to a different time zone and experiences a large family grouping, for example, or a party or celebration, it can just be overwhelming. Yeah. And that may be worthwhile considering, but then having the person have some space, a room where they're in, where people are around in smaller groups, for example. And this is someone with more advanced dementia. So to be thinking wisely about how you manage the environment.
Well, that kind of gets to my next question, what treatments or interventions are available to help a person with dementia and behavioral symptoms. So that's kind of one intervention when you're in social situations, maybe creating an environment that's a little bit less stimulating or a little bit less intimidating by having lots of people around. But are there other types of, prescription medications or treatments or interventions that could help?
Yeah, the interventions are in two categories. One are the behavioral interventions we've talked about a little bit already, and then the other is medications. To continue with the behavioral interventions that most feel are the most appropriate, perhaps the most successful interventions. We've talked about managing the environment and stress, for example, but also to remember that the person with Alzheimer's disease, the focus there is the 3 R's: repetition, redirection, and reassurance. Okay. That working with someone, they have a memory impairment and they may ask the same question more than once. Repeat it. That's okay. It tends to, sometimes carers get frustrated with that, but it can help them understand, the person with Alzheimer's disease understand, to get the information they need. Unfortunately, it's fleeting and they may need it again. Probably more importantly, as we've touched on already, is the reassurance that managing the affect and being comforting and calming, that sort of approach is helpful. And then redirection. If someone with Alzheimer's disease, for example, is getting frustrated or upset with something, it's time to take a walk. It's time to go do something different, just to get them, because often the concern they have is focused on whatever they're wrestling with. So to essentially distract a bit and to help relieve them of the frustration of what they're currently experiencing. That's behavior. We've talked about some things. We can come to more if you'd like. With medications, that we try and avoid medications if at all possible, that medicines all have side effects. And we've learned that some groups of medicines, like antipsychotic medicines, that are prescribed for agitated or aggressive behavior, sometimes for sleep, although that's not particularly wise in many cases, they don't work as well as we used to think. And I think many clinicians still overvalue what the accomplishments are of antipsychotic medications and may underestimate the risks or side effects. So that, unfortunately, antipsychotic medications as a group are currently the kinds of medicines that have been best shown to benefit to some extent, particularly agitated or aggressive behavior. But we try and reserve medications to that class and to low doses and to those symptoms in which there's a safety issue, a distress issue, if somebody is really chronically upset, that these medications can help. And then the actual behaviors, for example, aggressive behavior that really needs to be addressed as thoughtfully as possible.
Okay. It looks like we have a question here. It's not quite related to dementia, but to depression. This person has a sister who experiences depression, but has abdominal GI issues that is said to be related to depression. How is this so? Do you have any perspective
Yeah, I'm
on
not
that?
sure what the abdominal link might be in her case, so I can't really address that. Depression and mood changes, mood lability, irritability are not uncommon in Alzheimer's disease. De novo, again, I'm not sure about the link in this case to the GI distress. And there may be some GI illnesses, irritable bowel, for example, some people believe have a link to mood symptoms as well. But I think the more important issue is the mood symptoms themselves. And for good or for ill, depression in Alzheimer's disease tends to be more fleeting than it would be for younger folks who have traditional major depression, where there's a lot of hopelessness, helplessness, melancholia is the traditional term, whereas that's somewhat uncommon in Alzheimer's disease. But something that's certainly worthwhile attending to, and if the depressive symptoms are significant, to get help from a care provider and to understand what that's about, particularly if it's linked to a GI symptom that may be addressable.
Okay. Could you maybe speak a little bit more to the link between depression and dementia and Alzheimer's disease?
Yeah, it's an excellent point, that everything we've talked about so far today is related to when you have Alzheimer's disease, you may get these symptoms, these behavioral symptoms as a consequence or part of the illness. We're learning that these behavioral symptoms can emerge actually very early on in the course of Alzheimer's disease and may be apparent before people have memory difficulties. Things like apathy, anxiety are now known to be kind of near-term risks for an older adult who develops prominent apathy, for example, just disinterest or lack of enthusiasm. Obviously, that can be related to a lot of things, but that if you track folks who develop late life apathy over time, they're at greater risk for developing the memory impairment of Alzheimer's disease. So we're looking for that. And it's important to the field to understand these early symptoms. We also know that there's interactions between the biologies and psychology, if you will, that if you have amyloid protein in your brain based on imaging, with or without anxiety, it has an impact on what your course of memory change over time is. If you have anxiety with the same amount of amyloid, the average course of cognitive worsening over time is greater. There's been a study, Byron Creese and his colleagues at Exeter University in England did a study with healthy adults and gave questionnaires about new apathy, irritability, anxiety. We all experience these things over the lifespan. And those who had symptoms then just tracked over the course of a year their memory was normal at baseline, and their memory was still minimally impaired after a year. But if they had these symptoms, their memory as a group was worse. So it seems like for some people, these non-cognitive symptoms are probably early expressions of an incipient cognitive disorder that we think of the hallmark of memory, but the anxiety and apathy may be part of the illness itself. And then depression can be a risk factor. There's a sense that if an older adult has late life depression and is treated and is doing well, that their risk for developing Alzheimer's disease over the next 3 to 5 years is actually a little bit higher. So it's important to monitor folks over time and to think of these syndromes as being interactive and not just in their own categories.
Okay. Now, speaking about research, some of the work your colleagues in England have done, I was wondering if you could speak a little about the specific research you've been doing in this area of behavioral symptoms and dementia.
Yeah, we've been interested in quite a while, and we recognize, like many do, that these symptoms that we're talking about are a fundamental part of the illness, as we've addressed. They're also very common and have a big impact on quality of life, on caregiver distress and burden, on the risk for institutionalization, on healthcare costs, that when you have Alzheimer's disease with behavioral symptoms, your overall costs for healthcare are about 50% higher than if you don't have behavioral symptoms. So these are really, really important. So for me, it comes from working with patients and families and understanding what they need. We focused on two things. One is brain imaging studies to try and understand why do people have these symptoms, and there's some target there that we can see biologically that provides an opportunity for new interventions. And then we've also done some treatment studies and looking at folks who have agitated behaviors or other symptoms, doing traditional clinical trials to understand what medications can be helpful, what kinds of symptoms respond to treatment versus those that don't, so we can better use the tools we have available. And from the treatment realm and medication, develop treatments that are more effective than what we have currently and have fewer side effects is obviously an important goal. And it's an exciting time. There's new things going on in that area that's going to likely bear fruit in the short term.
Okay. Can you speak to some of those things that are going on? Are there any, active studies about that are looking to help people with behavioral symptoms?
Yes, I think the biggest realm, I think the medication studies are looking at two different domains. One is agitation because of its importance and concern, and the other is apathy. There's some treatment trials nationally and internationally going on looking at treatments for apathy using stimulants actually that show some benefit. That's still being looked at, and we still don't know exactly what doses and how best to do it, but that's exciting because apathy you may not think of as an important symptom, but carers tell us about how they feel kind of emotionally disconnected from their loved one. And that's part of the illness, just this limited enthusiasm for some people. There's also treatments for agitation using other molecules than antipsychotics. Escitalopram is a big national study looking at a traditional antidepressant that may be helpful for agitated behaviors. Pimavanserin is a new medicine that has been FDA approved for psychosis and Parkinson's disease, but there's some interest in understanding how it may apply to other dementias and other behaviors. That's all work that's ongoing currently with clinical trials, so we'll be hearing more about that.
All right. Looks like we have another question here from a viewer. Dr. Sultzer, could you please comment on people who have MCI with daily changes in ability to cope with fears that result in days when there are no behavior symptoms and other days or minutes that the fear is manifested in anger, anxiety, etc.?
Yeah, I think the variability of symptoms that this viewer brings up are not uncommon, that some symptoms are there one day and not there the next. And in reflecting back on what we've talked about, the question is if there's any sense about what promotes those days where there are more symptoms versus not. And MCI is an earlier form of the illness, so it's hard to pin it specifically to a cognitive disorder because that person doesn't have a cognitive disorder at this point. But to be able to understand what sorts of triggers there might be, like we've already addressed, and try and understand how then that can be used to help improve their well-being.
Okay, thank you. I was wondering if you could speak a little bit to your future research goals in this area now that you're a new faculty member here at UCI MIND, and what are some of your plans here for UCI?
Yeah, it's an exciting time for me and for the field and for UCI. That one of the things I'm looking forward to is expanding some of the work we're doing in my lab, as well as across the labs here at UC Irvine, the Memory Institute, MIND, to be able to take advantage of the rich infrastructure and the rich ideas and faculty who are here. There's a lot of interesting things going on, a lot of basic science work that gives us some opportunity to be able to think about translating the findings from those who are doing everything from stem cell work here to inflammation to other immunologic areas which are a strength of UCI MIND. How can we leverage those into thinking about better treatments, for example? So I'm looking forward to joining colleagues in some of the basic science work, which is a little bit further from my history, and also to move them forward into the clinical sphere so we can develop applications and translate the basic science work, quality stuff that's being done here into clinical tools.
That's great. Yeah, it's definitely an exciting time here at UCI MIND and around the world in Alzheimer's and dementia research. Looks like we have time for about one more question from a viewer. I'm interested in the research methods for the studies on meds for behavior, because we know that environmental and interpersonal approaches matter a great deal in behavioral expressions. How do researchers control for these factors when testing out new medications? Thanks, Dr. Sultzer.
Yeah, it's an excellent question. In the past, medication trials were done without really attending to these behavioral or other interventions, and just kind of assuming that if folks are randomized to an active medication versus placebo, that the other factors would sort of come out in the wash. Mm-hmm. That's now seen as kind of a less than ideal approach, as the viewer brings up. And so most studies now enroll people who have, say, for example, a particular behavioral issue. And for the first couple weeks or more of the trial, they institute kind of a standardized, thoughtful, but not real detailed behavioral intervention to get the system, so to speak, on the same page as far as behavioral interventions, some caregiver education, some other factors. And then those that improve over that open label early treatment then would exit the trial, because it's clear that those sorts of interventions are successful, helpful. And then those who have continued symptoms then get randomized to active treatment or not. Okay. So it's essentially embedding the behavioral interventions along with the medication trial, which is important because in the real world, we should be doing that all the time anyway. Mm-hmm. Pills aren't the answer for these cases overall, so that we're looking for medications that can address specific symptoms, but also want to have these behavioral interventions be part of all care, because that's the best way, probably most successful, and certainly the wisest approach.
Okay. Great question. And then I know I said that was the last question, but I want to ask one more that just came in from a viewer. Do you have any guidance for how to help our loved ones when they become anxious and want to be with us all the time?
Yeah, it's a good question. We've identified the anxiety component, and there the goal is just to try and identify what promotes anxiety and to be calming and reassuring. That's not always easy if somebody's really upset, and as a carer, there's often upset along with that because someone you care about is upset. But to be able to just kind of keep your finger on your own pulse at those times. The other issue that this question brings up is kind of what some in the field call shadowing. And sometimes people with more advanced Alzheimer's disease want to be really close to people who they're comfortable with. And we want to be close to people who we care about, but sometimes too close and for too long is more than what we want. And because there's other things that need to be done during the day. So coming up with strategies to calm people, that's where adult day healthcare programs, then there's other people around that someone can feel more attached to and give the carer a bit of a break. Finding things for them to do. If there's not a lot of stimulation in their day-to-day activity, they're more apt to kind of attach on to someone who's doing things. Some people provide tasks for people to do, for example, folding laundry, folding towels, because you can fold the towels, and this again is somebody who's got more advanced symptoms, unfortunately, fold the towels and then they can be unfolded and refolded. And that's sort of just that activity, people feel that they're contributing. It's purposeful and gives them something. It's a little distracting, isn't quite the right word, but may dampen their enthusiasm for being just right with the person who cares about them, but perhaps not all the time.
Yeah. Okay. Well, thank you for the excellent questions from our live viewers. And Dr. Sultzer, thank you very much for sharing your expertise and experience on this topic with our viewers. Really appreciate it. And we hope that you will join us for future episodes of this Facebook Live series. This is monthly, the first Friday of every month. And next month, April 3rd at 11 o'clock AM Pacific Standard Time, I'll be joined by one of the world's leading experts in Huntington's disease research, Dr. Leslie Thompson here at UCI. So if you want to learn more about Huntington's disease and how it relates to other forms of dementia, please be sure to join Dr. Thompson and me next month. And in the meantime, to learn more about Dr. Sultzer's research, clinical trials here at UCI MIND, and other research studies, you can visit our website at mind.uci.edu. Lastly, and most importantly, if you'd like to help our researchers by participating in studies at UCI, you can sign up for UC Irvine's Consent to Contact, or C2C registry at C2C, that's the number 2, .uci.edu. And those links will be posted in the comments field here for you. And then if you are, looking for resources for caregivers or for patients with dementia who are experiencing these types of symptoms. There's a lot of great local resources here in Orange County that provide supportive services, such as our partners at Alzheimer's Orange County in Irvine and the Alzheimer's Association chapter in Orange. So thank you very much for attending. Thanks, Dr. Sultzer, and we'll see you next month. Take care.